Good afternoon to everyone. So I'm really happy to continue this path, this strategy, this chapter about the full dental patient that we have started a couple of days ago. And I think I want to remark with you how it's important to have a good strategy in the treatment of this patient, because this patient really often are focused to achieve the best therapy with the best price, reducing cost, reducing time. And so I think that it's really important to be able to identify the best therapy, and I mean with the best value, with also a good balance in between cost and value of the therapy. So to find a good balance for the value of your money. And I think that it's really critical, this aspect, because this patient wants something really reliable, with a good function, with a nice aesthetic, and saving time and saving money. This is the reality that we have here in Italy, that is totally different from the reality that we have normally when we have patients that are focused to aesthetic therapy, so with veneers or other kind of restorative therapies in the aesthetic areas. And today we will consider the last two parts of this chapter of the dental patient. And the first one of this evening is the part 3, that consider the restorative strategies to analyze prosthetic outcome and the reliability. Because it's really important. I think that it's really important to have a good strategies. Good strategy in order to promote to our patient a nice therapy, a strategic therapy. And that I want to start this lecture number 3 with this slide, because this slide, in my opinion, it's something that describes really well the daily routine that we had, in particular 5-10 years ago, that we had in the past, because how we have stressed in the previous lecture, the occlusal aspect, the biomechanical aspect in the full dental patient, that is really critical. It's critical because we don't have periodontal ligament, we don't have any kind of specific proprioception from the periodontal ligament that make the system really strong, really rigid, and so our restorations can fail easily if we don't manage correctly the occlusion and, of course, the selection of the restorative material, but in particular if we don't manage correctly the strategy. And this is the first case that I showed to you in my first lecture, in the first slides. So it's a good patient, a wonderful case in terms of implant success, good bone support, amazing stability of the margins. But in terms of prosthetic success, we can say that absolutely we don't have a good success. We have a nice survival, but not a success, because we can see how here we had many chippings. And probably in this patient also in the next years some chippings could happen. And here you can see in high magnification exactly what I mean. Many chippings everywhere, both in the anterior than in the posterior segments. This chipping can be repaired with composite, but we know how, if we use the bonding procedures on porcelain fused to metal or porcelain fused to zirconia, unfortunately this kind of procedure is not so reliable, because it's not easy to achieve a wonderful adhesion between this structure and our composite. And at the same time, we know how it's not recommended to remove these prostheses from the mouth, to send back them in the lab and to ask to the dental technician to layer again some feldspathic porcelain. Because we know how feldspathic porcelain, after 48 hours that they stay in the mouth, they absorb saliva, they absorb water. And so it means that if you go in the oven again for modifications to repair some chipping, the firing process can create a strong elimination of water from the inner portion of the porcelain, and this can create micro crack that can compromise more and more the feldspathic porcelain reconstruction on the occlusal and on the buccal aspect of our rehabilitation. And I want to point out with you how also in case of titanium framework or any kind of framework that is then finalized with acrylic or with composite, also this kind of solution cannot be considered completely final. Absolutely cannot be considered completely final. And so this is the reason why, in my opinion, it's important to point out, it's important to find a solution that really can be defined final. And it's important to be honest with our patient and select exactly the final rehabilitation when really we can guarantee them. Look, for example, this patient, she is really young, is 47. These prostheses stay in the mouth for 7 years. She has a wonderful maintenance, really great maintenance at home, and she came in the office every 3 months. So we can see how we have a good soft tissue response. If we look at the prosthesis, of course, no fracture, but you can see how we add an important wear. All the teeth are really wear, and we can see how the wear make the teeth really thin. And so it means that probably in the next years, in the next months, only these teeth could be necessary to make a new reconstruction of new teeth, because when the teeth becomes too thinner, then the risk of fracture is higher. And honestly, this rehabilitation is one of the best rehabilitation that I have in terms of composite reconstruction or acrylic reconstruction. And of course, many clinicians consider that the idea to change the teeth with a new one after 5-7 years, it's something that is normal. It's something that is part of the therapy. And they like to do a comparison between like to change the wheels in the car, no? Every 5 years you have to change the wheels in the cars, and so it's normal to change the teeth in the prosthesis every 5 years. Honestly, I'm not totally agree with this kind of statement, because in my opinion, to change the teeth in the prosthesis is not like to change the wheels in the car. It's like to change the engine in the car. So, because it's an important job to do. It is also expensive. And so I think that we cannot promote this kind of rehabilitation like final, because it's the word final that can make us in a bad situation when the patient maybe could have problem in the future with some complication with the prosthesis. And this is the reason why in my clinic I like to approach the full edentulous patient with this kind of strategy. I like to divide the treatment plan, the complete therapy, into big different phases. The first one is the phase A, that consider the implant placement and the temporary abutment, the temporary restorations. So in this approach, in this part of the treatment, in the phase A, we consider always a new complete denture if the patient is candidate to receive a new denture, or if the patient already had an old denture, we make a new one. Then in the same phase of the therapy, we include the implant placement and the immediate loading, considering to rehabilitate the patient immediately with the fixed full acrylic temporary restorations created, converting the denture in a fixed temporary restoration, full acrylic. And then after the complete healing of the abutment, of the implants, when the implants finally would achieve the osseointegration, always we create a new prosthesis, metal reinforced, finalize with composite or acrylic, and we like to call this procedure like long-term metal reinforced temporary restoration. And the patient knows that these restorations can stay in the mouth per year, per month, per weeks. Depends on the biomechanical risk factor of the patients, depends on how the patient use these teeth. But it's important to consider that this prosthesis is not final. It is exactly like the final restorations that many doctors in many clinics all around the world prepare for their patients. But I don't like to call it final. I like to consider it always a long-term metal reinforced temporary restorations. And in this lecture, I want to be really clear with you about everything. And honestly, also in terms of marketing perspective, I like to promote and to consider for this kind of phase just a price, without to go in details in number of implants that I have to place, if are 6 or 4 or 5. No. Phase A has this price, independently from the number of the implants. Doesn't make sense to prepare a price in relation to the number of the implants. We create therapies, we sell therapies, and the therapies cannot be influenced from specific details. Do you know what's happened? That if you say, for example, I want to place to you 6 implants, and each implant costs maybe 1,000 euro, the patient started to say, okay, but if you place 4 implants instead of 6, maybe I can pay 4,000 instead of 6,000. So the patient push you to make some compromise for the therapy, when we know how it's important always to maintain a therapy reliable for our patients. So I don't want to be influenced from anything like that. So the therapy is like this. For example, phase A cost 13,000 euro. How many implants is my problem, is my concern. I will evaluate it intraorally with the scan, with the CBCT, with the digital software, but the cost, it doesn't depend on the number of the implants. It depends on the therapy. You are buying a therapy in this clinic, not just implants. I think that it's really important to stress this aspect, because we are doctors, we are dentists, we are part of the medicine, and so we are created and we sell therapy, not just object. It's not like in the supermarket, okay? So this is the phase A. And then if the patient wants a final rehabilitation, of course, we have also the final rehabilitation. And with the final rehabilitation, always I like to promote something that I want to, with a good guarantee. Because of course the patient asks for this. And for the final rehabilitation, we have 2 options. The option is to work with titanium or zirconia framework combined with monolithic restoration. like lithium disilicate, or to work with monolithic zirconia. But we will see better this part in the last lecture. What I want to stress with you right now is the strategic approach in the from the marketing point of view. Okay, and of course, when the patient has received the treatment, the phase A, and now, for example, she received or he received the metal reinforced temporary restoration, she can maintain it for also 10 years if the prosthesis works. And after 10 years, if maybe the prosthesis is completely worn and the patient has to remake a new one, the patient can always decide if to do a new long-term metal reinforce or if to make finally a complete final rehabilitation, so go to phase B. So it's important, this aspect. And you know why it's important? Because if you create a final metal reinforced rehabilitation with an occlusal reconstruction in acrylic, and maybe this patient in the future, after 6 months, after 1 year, can have a fracture or a complication or a chipping, the patient comes back to your office really angry. And the patient wants that you repair it immediately. And for free for sure, because it's final. And you have said to the patient it is a final rehabilitation. And for the patient, final, it means that, okay, no problem, it's final. While if you consider it like a long-term temporary restoration, there is the word temporary, the patient knows that it's something that isn't final. So if the patient will have a complication, and unfortunately can happen, when the patient will have this complication, she will call you, she will ask you an appointment to repair the prosthesis. The patient comes to your clinic, you will repair the prosthesis. The patient will say thank you, you will ask money for the reparation, and everyone is happy. This is really important in my opinion, because it's important to be clear with the patient. And if the patient tell you, for example, okay doctor, but in the other clinic they want to offer me a metal prosthesis with acrylic like a final one, and you can answer them, okay, you can do, but first ask them if they can guarantee to you the prosthesis for 10 years or also 5 years. If they say yes, maybe you can do the prosthesis and you can go there if you want. But of course, no one can do it, because everyone knows that with this kind of prosthesis, we can have this kind of problem. Okay? This is something that for me make the difference. And I have been starting to work with this technique more or less 8-9 years ago, and to be honest with you, it was a great game changer for the management of the clinic, for the management of my patients, because in that way I have less complication, and when I have a complication, it's not something that make me really frustrated, because it's something that I have already shared with the patient from the beginning. And the patient, all my patient that has this kind of long-term metal reinforced prosthesis knows that it's something that can have complication. And so when happen, everyone knows what to do. Complete also the patient. So we consider the temporary restoration. And I want to just to go in detail with you about the number of implants. And of course, this is for me the best situation that I can have in my clinic, in my patients. So the idea to place 6 straight implants, but to place this kind of 6 straight implant with the most distal implant located in the distal portion, distally to the nerve. So it means that this prosthesis will be without distal cantilever. It's something that is really rare, unfortunately. It's rare to find patients like this. But of course, when I have situation like this, the best solution is this kind of approach. All the implants are adequately placed, not adjacent, but with a good distance between each others. And the prosthesis is perfectly balanced from the occlusal and functional point of view. in all the other situations, so when I cannot do something like this, because it's the best solution, but unfortunately it's not really common, option B is this one. But it is not an option B because it's not good as this one. It's because we have to use this kind of approach when it's not possible to place this kind of implant distribution, because we don't have enough bone. Sometimes in my patient, I did also something like this. But honestly, I think that to place 5 implants in that way is not convenient. It's much better to avoid this implant in the middle, to calibrate better the position of the 4 implants, and to come back in this kind of option, to come back in the all-on-4. So in the lower jaw, this is what normally I do in my patient. When I can, because I have lots of bone, 6 straight implants. When it's not possible because we have resorption in the distal part of the mandible, all on 4. In the upper, the situation is the same. When I have lots of bone and if I can place 6 straight implants, I like to do this. But the problem is that, unfortunately, in the lower, if in the lower we have the nerve, in the upper we have the sinus. And so really often also in the upper we have to place the distal implant tilted in order to create an all-on-4, in order to work in really dense bone, in order to place really long implant and achieve good primary stability and reduce the distal cantilever. Sometimes in the upper jaw we have really situations that, anatomically speaking, are really complicated, and with the digital software is really a good option to look for the best implant sites where to place the implant. And sometimes we go also in the tuberosity area, where we have sometimes really good bone, soft, really soft, but at the same time is good from the biological standpoint. In that way we can use this implant in order to reduce the distal cantilever. Maybe we can place these implants, but we don't load them immediately, because maybe in this area the primary stability is not amazing. Maybe we can load only the first anterior one, the 4 anterior one, but not the implant in the tuberosity. But is an option that we can consider. And of course, in the upper, sometimes we have also the zygomatic implant. That is another option. Is an option that is really limited to the situations where all-on-4 and zygoma and also intrasinus implants are not possible. And I'm sure that Dr. Enrico Gagliardi and for sure will show you in his lecture a really well-detailed lecture about how to consider which kind of surgical approach select in each clinical situations. Sometimes we have also really border situation like this one, where we have really a super atrophy in this mandible, and so we are forced to place 5 implants, really short, 6 millimeter implants, that are placed with immediate loading, because in this case, even if the implants are really short, the bone quality is really high. And so in this situation where we work only in basal bone, of course we have a primary stability that is really high immediately. And so just to explain to you how it's the situation in terms of implant placement, implants area. And of course, in the 99% of my patients, we work with an immediate loading, because both in the upper then in the lower jaw, today we know how the immediate loading has really amazing results that are comparable to early or conventional loading. Okay, so in particular, if we speak about survival, are absolutely really similar. In particular, of course, this is a study that consider only full edentulous patient. So I think that today we have a really good scientific based evidence that describe how the immediate loading in the treatment of the full edentulous patient is something that is absolutely possible without any kind of complication. The most important thing is to respect the protocol, and the protocol consider, of course, to place at least 4 implants with a good primary stability, and to create immediately a prosthesis, maybe without too much occlusal load in the posterior segment, in particular in the distal cantilever, because we know how in that areas we have the maximum the maximum amount of occlusal forces. So from the clinical study, we know how the minimal torque that we can consider for the medial loading is 30 Newton, but I think that this aspect is absolutely a sensible message, just to give you this information. But honestly, when we work in the full edentulous patient, we can do medial loading also with implants that are 20 Newton, because first of all, 20 Newton is still a good value of primary stability, and at the same time, when we split together all the implants, this aspect achieved less importance respect than when we do the medial loading in case of single implant placement. Of course, when we speak about the immediate loading, the magic number that we know in terms of primary stability is the 35 or the 30 Newton. But this is a number that comes just from the concept that then the prosthetic components have to be torqued on the top of the implant at 30 or 35 Newton, depends on the implant system that we use. So it's not a scientific and biological concept that is behind this number, but it's just a prosthetic one. But of course, primary stability is important, and for me 20 Newton is a really a good evaluation, a good stability. About in all the situation where it's not possible to work with an immediate loading, maybe when we have to do GBR, are not really useful or really common in my experience to do GBR in the full edentulous patient, but sometimes can happen that maybe we have a patient with bone that is like a knife edge, you know, is like a knife. So we have a good vertical height of bone, but the thickness is really limited, is like a knife. And so in this situation we have to do, for example, horizontal augmentation, or maybe we place implants and we can make a mistake in the preparation of the sites, and maybe the implants can have really a super poor primary stability, like less than 5 Newton, and so in this situation we need to submerge the implant. But when we submerge the implant and we place on the top of the mucosa a denture, what's happened? Sometimes the compression of the denture can create fenestration, can create adhesions like this. So every single time that I have to place a denture on the top of my implants in the full edentulous patient, my recommendation is, okay, to use a soft liner to reducing the wearing, okay, so create something really soft in contact with the soft tissue, but at the same time it's really important to place our implant subcrestally, because in that way the residual bone that we have can also protect the implant, can protect the bone that is strictly in contact with the implant from the compression created by the denture. So maybe we could achieve bone loss of the coronal one, so a loss of the coronal bone that is located coronal to the implant, but not a loss of the bone that is in contact, that is in touch with the implant. About the temporary restoration in the full dental loss patient, we can have three different strategies. The first strategy, that is the most sophisticated, is when we have the chance to work totally with the guided approach. So we have the chance to create a model, a preliminary model with the implant replica located in this model, using the surgical guide to get the model. So in that way, our dental technician can create immediately a metal reinforced temporary restoration to be refined, to be fixed intraorally with some acrylic. And in that way, we can immediately create a really good temporary restoration. So also all these aspects are created before the surgery. The second approach is to convert the denture, the complete denture, in a full acrylic fixed bridge. And honestly, in my daily routine, this approach represents the 90% of my patient, because this approach is simple, reliable, and easy to do. The third approach considers to take an impression, a final impression, and to deliver the prosthesis not immediately in the same day, but after maybe 24 or 48 hours. Honestly, I don't like these procedures because I don't like to work with the patient 1, 2, 3 days after the surgery, because sometimes there is some swelling, the patient has some discomfort, it's not easy to record the centric relation, because of course in this situation sometimes we have to take a new centric relation, and you know, after the surgery it's not easy to manage all these aspects. So this is two my different approaches. The first one is mainly considered when we have to place also immediately implants. So we have to extract the teeth and we have to place immediately the implants, and we use this approach in particular when we have the chance to create a dental bridge. And so I want immediately to create a good temporary restoration that can support the soft tissue in the perfect position where they are, in order to reduce as much as possible the recession. But in all the other situations, in my opinion, this approach is the most predictable and the most simple to do. This is the first approach that I have mentioned to you. So we plan the treatment. Sorry, my friend. So in this case, I have planned my cases with the digital software, like for example DTX Studio Implants or something like that. I have planned my implant placements. I have got my surgical guide, and from my surgical guide, the dental technician, using specific components, can get the model. And here we have the model, the preliminary model. And then on this model, the dental technician creates this temporary restoration. And you can see how we have a dental bridge. So we don't have pink reconstruction. We don't have an hybrid solution, but this is a dental bridge. And this is important to work in this way when we have the possibility to work creating a dental bridge, because in that way my prosthesis can immediately sustain the soft tissue. It's the same concept when we do an immediate implant placement in the aesthetic area for single implants or for a couple of implants. It's important to place immediately the temporary in order to maintain the morphology and the scallop design. And this is after the surgery, the situation, and we can see how with this kind of approach we can really achieve nice temporary restoration in the first approach. So immediately with the first temporary restoration. But the most used approach that normally is convenient to use for our patient is this one. So to convert the complete denture in a fixed immediate temporary. because the technique is simple, predictable, and you can do it alone, or maybe you can have your dental technician in the lab for just 1 hour. And of course, also this procedure can be supported by the guided surgery, because of course also with this technique I can prepare my surgical guide, and I can use the surgical guide for the implant placement. If you for example work with a fully guided surgery, you can always get your model, and maybe while you place the implants, your dental technician can work with the denture on the model in order to prepare the denture for the ideal refining in the mouth. But as I have already said to you, I prefer to work with pilot drill guide surgery. So I use the surgical guide just for the first drill, the 2 mm, and then after I've removed my denture, my surgical guide, and I open the flap. In that way I can save a lot of soft tissue, and at the same time I can simplify my surgery because I have the first osteotomy already designed by the surgical guide. It's really important when we work with this technique, remember that the occlusal contact should be maintained only from the distal implant to the distal implant. On the distal cantilever, it's not important. No, it's not important. It's not recommended to keep the contact because this is a full acrylic prosthesis, and so the distal cantilever, if you don't have enough thickness, can be really risky to maintain. And about this approach, I know that many people, many clinicians around the world are really afraid about the idea to use this approach. But honestly, if we look at the scientific evidence, and if we look in the publication that we have, there is many schools, there is many clinics and many clinicians that use this approach per year, and they're treating a huge number of patients, placing a huge number of implants. And with this approach, the success and the survival rate at 10 years of follow-up is really high. So I think that we don't have to be afraid about the idea to splint together many implants with a not reinforced prosthesis, but I think that it's important to know exactly how to manage it, how to do it. And this is, for example, this prosthesis in the upper, how we transform it in this kind of procedure using the temporary abutment. And the advantages of this technique are that is the cheapest way to manage the immediate loading. We can reduce the time of the treatment. We can check the occlusion intraorally. There is no bite record because, of course, we convert the old denture, so the seating in the mouth of the old denture, even if we have opened the flap, is really simple and facilitated, and the occlusion helps us in order to find the ideal vertical position of the mandible and the ideal position. And of course, I like to keep this approach because we have always a denture. Maybe never happen, but for example, if we don't have the chance to do an immediate loading because, for example, we have underestimated the quality of the bone, and maybe we have prepared too much the implant sites, and maybe our primary stability is really 0 on all the implants, what we can do? We can place the implant subcrestally, we can suture, and we can place the denture. So this is the reason why I like to work with this kind of workflow. Because for the fully dentulous patient, for me it's important to have a workflow that is repeatable and simple to use and to adopt. The drawbacks of this technique are that we don't have cantilevers, so we have a number of teeth that range from 8 to 10 elements. Of course, it requires a correct vertical space because you know that we have a full acrylic prosthesis, So it means that the support, the biomechanical strength of this prosthesis has to be created from the volume of the acrylic. If we don't have enough volume, we need to increase the volume of the prosthesis just to create something with good biomechanical feature. And in fact, sometimes it requires the thickening of the palatal or lingual volume that, in some specific situation, could create small phonetic problems in the first weeks. The complications with this technique are really simple. Sometimes can happen that one temporary abutment after the setting of the acrylic, it doesn't really get stuck really well, but it has some small mobility, but it's not a big problem because we remove it, you place it again in the mouth, we place again the prosthesis, and maybe you screw the prosthesis on the implant because normally all the other temporary abutments are okay, and then you get a new, you prepare another set of acrylic and you can fix it again. Another problem is when we have screw holes on the buccal aspect, but we know how today with the digital software, but in particular thanks to the prosthetic components, we can work with angulated multi-unit abutment, we can work with angulate screw channel technology, so we can really have an access to our screw with a different angulation, compensating maybe not an ideal implant placement. So it's the problem of the screw holes placed buccally. It's a problem that today can be really fixed easily. And here is what's happening intraorally. Really often I like to ask to my technician to sandblast the temporary abutment in order to increase the link between the acrylic and the surface of the abutment. And look that always I like to place my temporary abutment. Here we have our temporary abutment on the top of the multi-unit abutment. So never I work an implant level in this situation. Today I love to work always on prosthetic level, and today always I like to work with intermediate abutment that are placed immediately during the surgery and that move my prosthetic platform more coronal. In that way I can simplify my approach and I can simplify also the life for the patient. Please, with this approach, no distal cantilevers. And I tell you this message really strongly because in my life in the past I have tried to maintain to keep the distal cantilever just for aesthetic reasons, sometimes in the upper, and I have tried to create some kind of reinforcements with fibers, but always I observed complication. So we have to prepare the patient that no distal cantilever in this phase. So if the patient has to stay 3 months with this prosthesis that can have from 8 to 10 teeth. That's it. Then when we will prepare the long-term temporary restoration, we can create distal cantilever because the prosthesis will be metal reinforced, and then in that way we can deliver a prosthesis with the 12 teeth. About the procedure, I want to share with you this approach that was described from the book of Enrico Gagliardi, and I collaborate with him with many cases. And the approach consider, of course, to have the denture that the patient wear for some weeks or maybe some months. It's important after the surgery to create a space in that area where the implant are placed and create also some notches, some retention for the silicone that now we go to place in that area in order to take a sort of impression, intraoral impression of the cover screw of the healing abutment on the top of the implant. This is a putty material, the silicone putty material, and then we go in the mouth. So the intraoral reline with silicone, with the 99 share, to register emergency and inclination of the prosthetic abutments and the actual position of the soft tissue after the suture. Okay, so we go in the mouth right now in this situation. This is an all-on-4 in the upper, and we place, of course, the healing caps on the multi-unit abutment, then we suture. Now the bone is protected, and so we go in the mouth with this. In that way we close, we ask the patient to close, and then in that way on this silicone we can see the position and also the angulation of the implants. And it's easy to place these prostheses in the mouth because there is the palatal. This is the palatal stop here that can help these prostheses to have a precise position intraorally. And the same story happens in the lower jaw with the molar area, because in particular in the retromolar area, we keep the retromolar area stable, and in that way also this area can help us to find the position of the prosthesis in the lower jaw. So thanks to the stop given by the palate and by the tuberosity retromolar triangle, it is possible to maintain the video to maintain the midline and also the occlusion. So it's really a good tip to work correctly. So the silicone completes the setting, and thanks to the rigidity it is possible to get a stable anchorage on the implants region. Look here. You can see the implants, and you can have exactly the idea of where the implants are located, and at the same time you can see exactly a little bit the angulation. So then you can drill the silicone and the prosthesis in order to open the area where are located the implants, like this. Okay, and then the setting, we are creating the setting area for the temporary abutments according to the information given by the silicone line in terms of position and inclination. So right now when we go in the mouth and when we want to fix the temporary abutment on this prosthesis, it's simple to find the position, and it's also simple to adapt the position, the prosthesis in the mouth. Sometimes during this phase we waste a lot of time because we are not able to create a correct hole without any interference with the temporary abutment. And what's happens then maybe sometimes we open the hole too much, and then it's more complicated to refine the prosthesis and to fix the temporary abutment because we have a hole that is enormous, that is really big. And of course, if we place a lot of acrylic in that area, we have also a bigger contraction that can compromise also the seating of the prosthesis, because you know that there is a contraction. So it's important also to reduce the number of acrylic that is placed in that area to fix the temporary abutment. Of course, we place some Teflon to cover the head of the screw, and then you can place also some rubber dam in order to be sure that the soft tissues are isolated, and then you can use acrylic, you can use composite, and this is the direct technique. So we fix immediately the prosthesis in the mouth using the material. Okay, so here we have used some pink acrylic, but of course you can also use a white one. In this area there is no any aesthetic concept. Then you remove the prosthesis with the temporary abutment that got stuck inside, and then you can go to put some new acrylic to reinforce again the stability. And then what you can do, you have two options. One option is to fill all this space with acrylic. Okay, so you have to remove first the silicone, and then you fill all the space with acrylic, and then you remove the palate and you refine the prosthesis. And this approach is faster, but is not really super precise. Or another approach is to get a model. So now you screw the implant replica here, you pour some pink silicone to recreate the soft tissue that you have in the mouth. So you get a preliminary model. Here you can see how we pour the plaster. So we have this model, and on this model we can go to refine really well the prosthesis. With this approach, the patients have to stay in the clinic for a couple of hours at least, because for all this process the dental technician takes a couple of hours. Okay, but here is the approach, the direct one. This is the normal that I used, where after to have fixed the temporary abutment with the acrylic, I remove the silicone, I put again new acrylic all around in order to reinforce the prosthesis, then I remove the palatal, and then you can finalize it. This is the approach instead when you create your model. And here is the prosthesis. It's really important to maintain a flat design, a flat profile of the resin in that area, because in that area we can have some swelling. So it's important to stay really flat in order to facilitate the oral maintenance, to facilitate the use of interproximal brushes, and to have also the chance to remove the suture after a couple of weeks. So in this case, we can see how the provisional restoration is delivered after 2 hours, how I have already mentioned to you. Is keeping full occlusion from the canine to canine, slightly contact on the premolar. This is really important. So in this approach, remember that the major contacts has to be placed from cuspid to cuspid, because we know how in that area the forces are really minimal, and in that way we can preserve the implant from strong occlusion, in particular if you have a patient with parafunction habit. Absence of interference in the lateral excursion, no molar are set up of this temporary stage, so please no cantilevers. And here is how the patient received temporary. But about the stability of this approach, it's really important to remember that a crucial aspect is the section, the volume of the prosthesis. If you have a full acrylic prosthesis like this, with this kind of thickness, with this kind of height, of course, probably you don't have any risk in terms of fracture, because this kind of prosthesis with this kind of thickness has the same strength of the metal, maybe not probably exactly the same, but for sure achieve really incredible result, really similar to the metal. So in my personal evaluation that we have already considered like a topic of this study that we did together to Professor Sorrentino at the University of Siena, Italy, is to evaluate the strength, the clinical performance of 15 identical specimens produced for this kind of clinical situation, and that they represent exactly the scenario that we have when we manage with a Nolon 4 with a full acrylic the posterior segment. And we create 15 identical specimens, but 5 resin based with metal reinforced, 5 with complete full acrylic, and 5 with full acrylic and prefabricated teeth. And we decided to test all these specimens. But the most important thing is to consider that all the specimens had an area in the section area of 90 square millimeter. Why? Because after an evaluation of all the cases managed at that time in our daily routine, we have evaluated the mean of the area that we had in our rehabilitations, and so in this study the specimen had this area. Okay, this is really important because, as I already mentioned to you, is the volume of the acrylic that created the clinical performance. And so we stress all the specimen with this progressive load from the occlusal aspect. And this is how we stress all of them. Of course, it's an in vitro study that we did in the lab. And here we can see the stress of, we can see how we test all the 3 kinds of specimens. Okay, this is the metal reinforced, This is the full acrylic, and this is the full acrylic with the teeth from the market. Okay, so using the teeth that normally we use for the denture. So we stress all these spacement up to the fracture. And it was nice to observe how, of course, the metal reinforced achieve the highest number of performance. So they withstand up to 1,400, 1,700, and up to almost 2,000 Newton. Complete full acrylic, we have a more heterogenic result, but we range from 1,800 to 1,200. And then we have fully acrylic with the fabricated dentition that range from almost 1,900 exactly and to 1,800. So it's really an heterogenic result and this aspect explain how the performance is not good as the metal reinforced. But please have a look to the numbers that we achieve. We speak about 900 Newton. And please consider that we have to keep the occlusion from cuspid to cuspid, or maximum to premolar to first premolar to first premolar. So it means that in that area, to find the patient that can really achieve 900 Newton, it's really not possible, because we know how we can achieve 1,000 or also more in the molar area. In the front teeth from cuspid to cuspid is not possible to achieve this kind of value. So it means that also the full acrylic approach, if is used and managed correctly, allow us to get good result. And in fact, this is what I do normally in my patients. And we have also other study that describe in vitro how the full acrylic approach can be comparable to the metal reinforced one. In particular, if we exclude from the rehabilitation distal cantilever, because it's on the distal cantilever where the presence of a metal reinforced can have a significant impact on the biomechanical performance. Then there is the third option, that is the metal reinforced after an intraoral impression. And this approach consider also always to use this kind of temporary abutment, and consider of course to make a wax up, to make all the procedures that normally the dental technician does in the lab. So you place the temporary abutment, you prepare the framework that can produce with CAD/CAM technology or with the lost wax technique, depends on the preference of your dental technician. Then you fit it on the temporary abutment, and this framework of course is cemented on the top of this temporary abutment. Really I strongly recommend to you always to protect the interface area of your restorations with this kind of silicone cap that really often we produce, because otherwise how your dental technician can protect this interface if you sandblast it? When you sandblast the framework, it's easy that some sand can go in this area and compromise the stability or the roughness, or maybe can create a roughness surfaces that we know how we don't want roughness surfaces in that area. So really I recommend to you to protect that area, and then the framework can be cemented on the temporary abutment. And of course it's cemented with a specific cementation technique for the lab, but you can use also, for example, adhesive cementation, like any kind of adhesive system. Then you put the opaque, and then you prepare all the approach in order to create the acrylic reconstruction. And so after 2-3 days, you can deliver this prosthesis in the mouth. But of course, the patient has to stay for a couple of days, 3 days without teeth. And unfortunately, the patient then needs to become in the clinic when probably the patient still have a swell, pain. And so manage the patient in this situation for me is not comfortable. So honestly, this approach is not really my technique. And honestly, as I have already said to you, I like a lot to use the denture, or maybe I like a lot to create a temporary restoration using a guided approach, using a digital workflow where I can get a preliminary model from the surgical guide. Again, I want to stress with you another time the importance to work at the prosthetic level and always to place an intermediate abutment, in particular nowadays where we work with the plasma switching implant and conical connection, because the only way to keep also in the full edentulous patient this kind of configuration is to work with this kind of multi-unit abutment. Because if you place a prosthesis directly at the implant level without to place the multi-unit abutment, it means that you lost the plasma switching, because then the prosthesis will be flat to flat, and so you don't have the plasma switching. So in that way, you can see how also in the full edentulous patient we can get this kind of really good integration at the bone level. The biological width establishment and the bone remodeling, it's a topic that for me nowadays is really crucial. It's really important to understand how to preserve the bond around our implant. And we know how the biological width establishment around our implant, it's something that is multifactorial. Depends on many aspects, many parameters like soft tissue, connecting design, surgical trauma, overheating, bone compression, connection stability, implant abutment surfaces. But there is another piece of the puzzle that is the patient-related factor that depends on the immune response, oral hygiene, the habits, periodontal disease, systemic condition. So it's a piece of the puzzle that unfortunately we cannot control. Because of how many times we have really strange radiological evaluation in some patient where maybe all the surgery, all the prosthetic situation, and in particular maybe also the patient environment seemed really good. But sometimes we can observe a little bit some bone remodeling. And I like to work with this kind of multi-unit abutment, or maybe this intermediate abutment also in the full edentulous patient, because with this patient, with this approach on this patient, really we can get this kind of great soft tissue adhesion. And it means that you are able to create really good MOOC integration. And remember that if we have a good MOOC integration, it means to have also a great bone integration, because the soft tissue seal represents a protection for the bone. If you have not an amazing bone integration, but the MOOC integration is great, is good, of course your implant is safe, because you have the good seal that protect the surrounding bone. But if you don't have a good soft tissue seal, if you don't have a good MOOC integration, your bone, even if it is wonderful, with great stability in the beginning, then can have problem. And if you think on this concept, working with the right abutment, with the right approach, we can have really this amazing cell contamination of the abutment surfaces. This is epithelium cells. Here we can see, we have to speak about cells with the 5-6 microns of diameter, and how you can see here we have really a good portion of soft tissue that remains stuck on the absolutely on the surface of the implants. So I like the concept to work with the system that can allow a great bone integration and at the same time also a great muco integration. And so we have systems that consider a specific gradient of roughness from the collar to the transition zone, finalized to achieve the ideal integration at each levels. Because remember that the implants normally always were focused on bone. But now it's time to move also to the importance of the soft tissue. And so it means that if you want to achieve a good integration at each levels, so from the soft tissue to the bone, of course the bone requires different specific properties respect the soft tissue. And then I want again to stress with you some aspect of the tilted implant from the prosthetic point of view. For sure, when we place an implant, a tilted implant, we have the chance to place an implant with a longer, that is longer respect the traditional one. Because in that way, we can place the longer implants, and the implants can also follow a dense bone structure, like for example, the anterior cortical of the sinus. The implant support is moved posteriorly, because otherwise the implant should be placed here. And then we reduce also the distal cantilever. And normally in this situation we place the tilted multi-unit abutment, like in this case, that give us the possibility to maintain a specific emergence profile, and it can simplify our prosthetic procedures. Look here, for example, if I have this multi-unit abutment like this, I can screw my prosthesis that way. That absolutely is really simple. Sometimes I like to use also in the posterior area on the tilted implant, I like to use also a straight multi-unit abutment. In this way, I know that is really more complicated to work, because we have to engage the screw, moving the screwdriver really distally. And so it means that it will be complicated, in particular if the patient cannot open a lot the mouth. But in that way, placing a straight multi-unit abutment, we have the chance, look here, to reduce the prosthetic cantilever. Not the cantilever from the implant, but that prosthetic one. And this is really interesting, because really often when we have to do, for example, a full arch in zirconia, many companies don't allow to have a zirconia framework with more than one cantilever. So in that situation, for example, if you place a tilted multi-unit abutment, your screw will be located here, and the cantilever is longer. While if you place a straight one, your screw chest will be here. And so, playing with the software of the CAD/CAM technology, in this situation, we have the chance to achieve a longer prosthetic cantilever. So, I want to conclude this my third lecture, stressing again the importance of the implant abutment interface, and with its biomechanical and biological implications. It's important, it's really important to protect the bone to implant interface. It's really important to preserve the soft tissue seal and simplify the clinical procedures. And in particular, it's important to work with the concept, with the system, with the prosthetic components that allow to work without any possibility to disturb tissues during the healing. And this is, for me, is really crucial, is a must, in particular in the full edentulous patient, to work always at the abutment level. So place the abutment immediately during the surgery, an abutment that normally move your prosthetic interface more coronal. The height of the abutment can be evaluated in relation to each clinical situation. What I can tell you is that I like always to maintain at least 3 millimeter from the implant platform to the soft tissue level, to the pharyngeal margin. And in this situation, I place a multi-unit abutment with a height of 2.5 millimeters. In the fully dentulous patient, absolutely 2.5 millimeters is for me an ideal option, because allow to work really at the soft tissue level to keep just the margin 0.5 millimeter subgingivally, or sometimes where we don't have enough soft tissue thickness, we can use the 1.5, or we can use other dimension. But of course we have also option with important height. For example, we have also multi-unit abutment 3.5, 4.5 when I have a loss of soft tissue, like in particular in the upper jaw, in the molar area. So it's something that can be managed easily in each clinical situation. Remember to move the prosthetic interface more coronally.